Okay, excellent. Good morning, friends. Now we'll continue with our anatomy session on the skull base. Last week we looked at the anterior cranial fossa, so we move on to the middle cranial fossa as a continuation. And next week will be the posterior cranial fossa. So what are the things we're going to discuss today? What are we going to look at? We're going to look at the central skull base, which is mainly made from the sphenoid bone and its extensions. We will look at the various communications between the sphenoid bone and really with the front of the bone, which is the orbit, the maxillary sinus, and inferiorly, which is really into the upper neck. And in there, we will discuss the intricate anatomy of the pterygopalatine fossa. What we have done before, and I won't really be spending much time on, is the anatomy of the pituitary gland and the pituitary fossa. We have already looked at the cavernous sinus when we discussed the venous anatomy, and we have already looked at the internal carotid artery anatomy when we talked about the cavernous sinus, and of course we looked at the cavernous carotid anatomy before. And earlier on, we have looked at the nerve anatomy when we talked about the cranial nerves. So the session is really mainly based on looking at the bony component and some of the neural component, and that's what we will discuss today. So let's begin. Okay, so this is the area we are going to be concentrating on. So we have looked at the anterior cranial fossa. Next week is going to be the posterior cranial fossa along with the anatomy around the foramen magnum. But today we are going to be looking at the middle cranial fossa, but also more importantly the central skull base, which governs a lot of the structures, is an important relay point, not just from front to back, but also from superior to inferior. So this is the anatomy we are going to concentrate on. And the anatomy really is based around the sphenoid bone, and you can see the sphenoid bone here, which has a central component and then which has a lateral component. Uh, and that's where we will be concentrating our efforts on today. Let's step back in time. Let's step back in time and see how we have evolved over the years. Uh, and this is really very crucial to understand when we see why our face and the skull base and the brain has modified over the years, over the phylogeny to be as it is what we are today. And perhaps it will also give us an insight as to what may happen to us if the evolution carries on. So I've put some timelines in there, and one of the most important timelines uh, is the capturing of fire by the Homo sapiens. So by capturing, as in we have learned to master the fire, and that was a very important landmark in our evolution, because that enabled us to cook food. And cooking of food enable us to digest it much more quickly, be able to spend our time less time on chewing and digestion, and we could do other activities that necessitated. And that is very, very relevant, because that allowed us to evolve our jawbone. And you can see over a period of millennia how our jawbone from the early primates, which had a significant prognathism, also the facial skeleton protruded substantially in front of the orbital ridge. And over the evolution, you can see how the orbital ridge has become quite prominent, but the facial skeleton has slowly regressed, so that it is now barely protruding in front of the orbital ridge, apart from the nose tip and for the mentum. And this has much significant bearing to the evolution of the central skull base. And it is not just because of how the brain has evolved. Of course the brain has evolved, and that has enlarged our cranial cavity, but along with that, along with the intelligence, the evolution of use of fire has has also allowed us to uh, uh, allow use of a different enzyme activity which was not found earlier on, which was the amylase, and which was being secreted along with our salivary glands and in the pancreatic juices, allowing us to devour the starch based foods. and that then enabled the mandible. The task of the mandible became less and less relevant, and you can see the teeth, which were very, very strong earlier on, have become slowly smaller over a period of time. So why am I talking about the evolution of the face when we are talking about the development of the central skull base and the sphenoid? Well, what that has done is, because of the reduction in the size of the facial skeleton, that has led to proportionate reduction in the size of the central skull base, not so much as in the anterior-posterior direction, but has been remained concentrated really at a very small portion. And if you look at the size of the sphenoid bone in comparison to the entire face, it's a very compact, small area, and this is what has caused a very compact area uh, right in the skull base. And somewhere in there, speech is also extremely relevant, because you can see, for a speech to evolve, it needs not just articulation around the mouth and the tongue, but also phonation coming from the larynx. And initially these structures were very widely spaced apart, but because of evolution of the sphenoid, which became progressively shortened, and also evolution of the face and the mouth, which is also progressively shortened, and the larynx was elevated, these were all triangularly coordinated quite close to each other, as opposed to the early primates where this was not possible. So that's kind of the setting, if you like, as to why the sphenoid is centrally located, but such a small portion, and has regressed progressively over in terms of size, but has evolved substantially in terms of its function. So let's go now a step further. We have seen how the phylogeny is evolved. Let's look at the ontogeny. Let's just remind ourselves as to how the skull base has evolved. Now, just a quick reminder. Really, we have looked at this when we discussed our embryology discussions. We have looked at the trilaminar disc, which is formed following induction by the notochord, which induces the surface ectoderm to form the neural groove and the neural plates. And here we have got the neural tube, which is formed after induction by the notochord, and it is this neural tube which is going to form the central nervous system. But it is this notochord which has been really the bandmaster, if you like. It's conducting the orchestra from over here, relaying all the information for development of this neural tube and the neural crest cells. Similarly, it is this notochord which is going to induce the changes around the neural tube in the mesenchyme surrounding it, and it is this mesenchyme which is going to be responsible for development of the skull base. It is this mesenchyme which is responsible for the chondrification of the skull base. So another basic concept. So yes, notochord is extremely relevant, and this is just the cranial end of the notochord that we are seeing here, and these are the occipital somites, and we have talked about some of the hindbrain development and the relevance of uh, these somites. And it is this notochord which is going to govern the formation of the skull base. Now, I've said in brief, really, skull base is formed from a cartilaginous model, as opposed to skull vault, which does not have a cartilage, but it's got a membranous model. So if you compare to the pelvis bone, which has a cartilaginous model, as opposed to the clavicle, which has a membranous model, so similarly the calvarium has a membranous model. And it's very important to understand that fact, not just because it's got an embryological root, but also when we're looking at a pathology. If you have got a skull base mass lesion which is bony, uh, you will think of course, aggressive lesions and benign lesions, but somewhere you will think that yes, there is a cartilaginous remnant in there, and hence you would have to think of a cartilage based tumor like an osteochondroma or a chondrosarcoma, as opposed to something from a skull vault which really does not have any cartilage base on it, and hence you don't really see chondrosarcomas or enchondroma within the skull vault. So the skull base is derived from a cartilaginous model, and it's governed, as I said, it is this notochord which really is the which governs that orchestra, and hence we call the models as paracaudal adjacent to the notochord, or precaudal over here. And these paracaudal models will eventually, along with the surrounding mesenchyme, give rise to the otic capsule. But for our today's discussion, it is this precaudal uh, uh, mesenchyme which is going to form the sphenoid bone derivatives. Uh, just a little bit more of detail over here. I'm going to spend a little bit more time just to discuss. It has got clinical applications to it. So the sphenoid itself is formed by various components, and it's got you will come to the anatomy, actual anatomy. It's got a central body itself. It has the lateral wings, the greater and the lesser wing, and each of these structures is formed by different cartilaginous models. So we have got the central sphenoid body, which is formed by the hypophyseal cartilage over here, and the central pituitary gland which develops in there. And then we have got the lateral models, which are the orbitosphenoid, which is going to give rise to the lesser wing of sphenoid, and the sphenoid, which is going to give rise to the greater wing of sphenoid. And these cartilage will eventually get ossified and unify with the central component of the sphenoid sinus. So this is what we are accustomed to seeing. This is what we are seeing here now. This is the middle cranial fossa. We have got a central skull base formed by the sphenoid bone itself, the lateral wings of the sphenoid. We have got a greater wing over there, and then we have got a lesser wing over there. And it is this central portion that is derived from the cartilaginous model. So this is what we were looking at. We had the occipital bone, which was formed from the occipital somites. We've got the foramen magnum, and as you come over here, this is the last occipital, or rather the first occipital somite, which is going to form the basi-occiput. And in front of that, we get the precaudal cartilaginous model, which forms the sphenoid body itself. As I said earlier, we have got a central component and the lateral components. The front component in the lateral is the orbitosphenoid, which is going to form the lesser wing of sphenoid, which is this structure over here. And then we have got the sphenoid, which is going to form the greater wing of sphenoid, which are these big wings on either side. And if you look at the central skull base, which is formed from two components, one is what we call as a pre-sphenoid, which forms mainly the body of the sphenoid anterior to the tuberculum. And we'll come back to the anatomy of that. What do I mean by that? So if you consider this as the sphenoid in entirety, what we are not seeing here is this lower component, which is formed by the basi-sphenoid. So the clivus is formed by the basi-sphenoid inferiorly, which is part of the occipital somites, but superiorly it is formed by the basi-sphenoid, which is post-sphenoid in derivative. So coming back to the development of the central skull base of the central sphenoid body, we have got the pre-sphenoid and the post-sphenoid. The pre-sphenoid is the one which forms the tuberculum sellae, and the post-sphenoid is the entire pituitary fossa, entire sella, and also the dorsum and the basi-sphenoid. So this is the post-sphenoid, and this component, just small component here along with the planum, is a pre-sphenoid. So that's what the cartilaginous models eventually will achieve later on. And this is just a pictorial representation of the same. Anteriorly, we have got the ethmoids which are developing, and then we have got the sphenoids which are developing here, along with the basi-occiput, which is part of the occipital somite. And what we tend to see is a small linear lucency, and I will come back to that in the next slide, which are basically the synchondrosis. So sometimes you see small lucencies within the bone, which are the non-ossified parts of these cartilaginous remnants. So again, just to quickly summarize, we have got the central skull base, which is formed by the body of the sphenoid, and laterally we have got the wings of the sphenoid. The wings of the sphenoid are derived from the lateral mesenchymal derivatives. The orbitosphenoid is going to form the lesser wing. The sphenoid is going to form the greater wing, and the pre and the post sphenoid cartilage models are going to form the sella turcica and the dorsum and the tuberculum sellae. So that's kind of the embryology. Okay, let's try and look at some of the clinical relevance of this. Why is it important for us to understand? Of course, when we see CTs, in children especially, you might see these lucencies, and it's very important to understand that these lucencies are seen normally and not to mistake them for fracture. And if you see these lucencies, because these are the cartilaginous remnants which have not yet ossified, the fusion has not yet occurred, and this fusion can occur much more later on. So you have got small synchondrosis here. Anteriorly, you can see between the ethmoid and the sphenoid, which is what you're seeing over here, the cartilaginous remnant between the ethmoid and the sphenoid over here. And sometimes occasionally in a very young neonate, in the first few months of life, you can see the intersphenoidal synchondrosis. And I talked earlier on about the spheno-occipital synchondrosis, which is part of the clivus itself. So the clivus is all of that in its entirety, and you can see this big lucency over here, which is basically the cartilaginous remnant between the basi occiput and the basi sphenoid. Again, not to be mistaken for a fracture. The one thing we have not talked about, but we have spent a great amount of time when we talked about the anatomy and the development of the pituitary gland, is the craniopharyngeal canal. And the craniopharyngeal canal is really linked to the development of the pituitary gland. Just a quick recap really of the pituitary development. This is not the craniopharyngeal canal. This is the spheno-occipital synchondrosis, so which is this structure over here. The craniopharyngeal canal is here, which is along the floor of the sella turcica, and it basically reminds us that the pituitary gland is derived from two sides. One is a downgrowth from the third ventricle, from the diencephalon, where you get outpouching, the hypophyseal derivative, and then the other is the Rathke's pouch, which is a cranial extension from the oropharynx, which is the Rathke's pouch, and these two meet together within the sella. But it is this Rathke's pouch which can be sometimes seen as a canal if it is not completely obliterated, and you can see it as a small lucency, and that is a craniopharyngeal canal. Normally within the first few months of after gestation, it will involute within the first 6 to 7 weeks, but sometimes occasionally you can see it being quite enlarged or patent. For example, in this case, the anatomy here is, this is the sphenoid sinus, this is the anterior wall, this is the posterior, this is the dorsum, dorsal aspect, and you can see how enlarged this pituitary fossa is, and there is a big excavation within its floor, and this is another patient over here. The anatomy, this is anterior, this is posterior. You can see the brainstem, and you can see this is the third ventricle over here along the floor, and you can appreciate how the third ventricle extends inferiorly, and there is a meningocele along the craniopharyngeal canal. So this is a craniopharyngeal canal. So this is just some of the remnants that you might expect to see, or some of the lucencies that you might expect to see in a neonate or in a young child. But occasionally in an adolescent as well, you can see some of these presenting as nasopharyngeal protuberances or masses. We talked about this briefly about the pneumatization of the sphenoid sinus last time we talked about the anterior skull base, but as sphenoid is really a middle cranial fossa derivative, it's really a central skull base derivative. I thought it's worthwhile just recapping that. And its relevance, of course, we have talked about is when an endoscopic surgeon is going to access the sphenoid sinus, either for the pituitary gland or for the clival lesions in that region. And it's important to understand that the sphenoid sinus can be variably pneumatized, and depending upon the degree of pneumatization, you can see the depth of the bone still remaining, separating the sinus from the floor of the sella turcica or from the posterior wall of the dorsum sellae and the clivus. So here you can see how the sphenoid sinus is really aerating only the anterior aspect of the sphenoid bones. Remember, the sphenoid bone is all of that, not the lower third of over here. The lower third is really occipital derivative, but the sphenoid bone is all of that in entirety. But the sinus has pneumatized only the small part called the choanal part here anteriorly, whilst in next patient over here you can see the pneumatization has extended further posteriorly, reaching the anterior wall of the sella. This is, and then this one here, it has extended far too deeper, reaching up to the posterior wall of the sella and the dorsum. And this is a very well pneumatized sphenoid sinus. This is moderately pneumatized, and this is poorly pneumatized sphenoid sinus. And you can understand the degree of bone drill that has to go through to reach the appropriate site for the surgery. So this is kind of the pneumatization that we understand in the sagittal plane, but CT has enabled us to look at another different pattern of pneumatization. In that, the pneumatization can be asymmetric. So these are some axial slices of the brain and MR scans. You have got a CT scan over here. I will just go through the CT scan. It's a little bit easier to understand. So this is an axial CT scan. We can see the it model air cells over here. We have looked at the anatomy of the it model labyrinth last week. The orbits on both sides. We've got the petrous bones over there. So this is the middle cranial fossa. This is our middle cranial fossa, central skull base. Here you will realize now immediately this is the spheno-occipital synchondrosis, not to be confused as a fracture, which means this is the basi-occiput and part over here is going to be basi-sphenoid. And you can see this is the sphenoid sinus, which has pneumatized quite substantially the right side of the sphenoid bone. But on the left side, you can see that the sphenoid sinus has relatively less occupied the sphenoidal bone, and there is poor pneumatization, or as we call it, arrested pneumatization. And this can leave an area here within the bone which looks quite different than the other side, and it can appear a little bit loosened, and you can see small punctate areas of calcification within him. And sometimes if you're not careful, it can be called as an aggressive lesion, especially if you realize that there is no bone on this side, but this bone looks quite abnormal. It looks as if it is expanded. But if you look on the soft tissue window settings, you'll realize that this has got fat, and that's what we are seeing over here on this MR scan, slightly heterogeneous, but a predominantly bright T1 signal with small speckled areas of low signal, which is basically the calcium within it. And this is the appearance of arrested pneumatization, which basically results in this appearance at the posterior aspect, along the posterior aspect of the sphenoid sinus. If in doubt, of course, you can perform a bone scan or an interval scan, but this is what an arrested pneumatization of sphenoid sinus will look like. Right, so we go beyond the development now. Now let's look at the actual anatomy of the sphenoid bone. The sphenoid bone, okay, it's located right within the center, a very, very compact area within the central skull base, behind the anterior skull base, in front of the posterior cranial fossa, and behind the maxillary sinuses and behind the facial skeleton. So very compact area, but a very, very deep area as well. If you look at the anatomy, it's got this appearance of a bird. People call it as a bat with a wing opened up. So if you have got the body of the bat, and then you have got the wings of the bat. We have talked about this earlier on. We have got the greater wing of the sphenoid, the lesser wing of the sphenoid, and the main body. But also there are two pterygoid plates, and we look at the anatomy of these individual structures and the apertures in a minute. So you've got the body of the sphenoid, the lesser wing, the greater wing, the various foramina, the various apertures that pass through the sphenoid, uh, and the pterygoid plates, which are at the back of the maxillary sinuses and the palate, and very, very crucial, very, very crucial in terms of governing and and ensuring the swallowing mechanism is when controlled, because these are where the constrictor muscles and the pterygoid muscles attach. Uh, so the sphenoid, okay, so we have set the stage as to where the sphenoid is. We have looked at its various components. So now let's understand in a little bit more detail about the anatomy of the sphenoid. Right. So when we look at the sphenoid, we will start first of all with the central component of the sphenoid. We'll look later on at the wings of the sphenoid. So the central component of the sphenoid is really the body of the sphenoid, and the body of the sphenoid starts where the ethmoid ends. So the ethmoid here is the yellow bit, which is formed by the olfactory groove on either side of the cribriform plate, and this blue area here is a very flat structure which is about in this location, which lies just above the sphenoid sinus, and it is flat. It's a plane. It is a plane of the sphenoid sinus called as a planum sphenoidale. And as you approach more posteriorly, you come across a groove on either side, which runs transversely towards the optic foramina, and this is the pre-chiasmatic sulcus, and it leads more posteriorly into slight elevation that you can sometimes see, and that elevation is the tuberculum sellae, and it is this tuberculum sellae which then separates the planum from the sella itself. It is this tuberculum sellae over here, and you can see this is a patient with a meningioma, and you can see the sphenoid sinus. This is the aerated component of the sphenoid sinus. This is the bony component which is not eroded. This is the dorsum sella. This is the enhancing pituitary gland with the infundibulum. This is going to be the planum sphenoidale, and this is the meningioma, which is based epicenter on the tuberculum sellae, but with extensions into the anterior skull base along the planum sphenoidale, but also into the sella as it dips into the planum. It dips over the tuberculum into supracellular cistern contacting the superior surface of the pituitary gland and also the anterior wall of the infundibulum. So this is the anatomy of the Planum sphenoidale and the tuberculum sellae as it dips down towards the pituitary gland. So the other structures to look out for here in the within the sphenoid body are the clinoid processes, and we have got the anterior clinoid processes. There are two on each side. Similarly, there are posterior clinoid processes which are also two on each side. So you've got the anterior here, and then there are small posterior. The anterior ones are much more dominant and much more easily seen and much more consistent, while the posterior clinoid processes are very inconsistent in terms of their size, and sometimes they can just blend in with the dorsum. And this is the dorsum, which is really the dorsal aspect of the sella. uh, the anterior clinoid processes, of course, are lateral. So in the midline section, we don't see them. We see them along the lateral aspect of the sella. So we have got the planum, we have got the tuberculum sellae, the chiasmatic sulcus, the anterior clinoid processes, the floor of the sella turcica, and then the dorsum of the sella, which then slopes down towards the clivus. So the dorsum, which is going to slope down towards the clivus, and this lucency now, you'll easily remember what we talked about. This is the synchondrosis between the basi-occiput and the basi-sphenoid, which is around about this level over here, this sclerotic line, which is the junction between basi-sphenoid and basi-occiput, both of which will eventually form the clivus. So this is the main body of the sphenoid. Let's move on to the wings of the sphenoid. So we talked about it earlier on. We have got the greater wing of sphenoid and the lesser wing of sphenoid, both of which are attached to the body of the sphenoid, and both are arching laterally. This is an exocranial skull base view. Looking at it from the outside, you can see this is the greater wing of sphenoid. It extends along the floor of the middle cranial fossa, extends laterally. Over here is going to be the orbit. You can see how it's laterally reaching out towards the orbit and then extending more superiorly towards the temporal bone. This is a CT scan, and just to show us again here, this is the greater wing of sphenoid along the floor of the middle cranial fossa. And we'll look at the anatomy in a bit more detail of this greater wing in a minute. Whilst the lesser wing is a much more smaller structure, which is located around about here. So these are the lesser wings. So again, to look at the anatomy, these are the sphenoid sinuses within the sphenoid body. On either side are the greater wings, this pink, red in color. These are the greater wing. The lesser wings are much smaller structures located along the superior aspect of the sphenoid sinus. And this foramen in between the lesser wing and greater wing, we have looked at this last week, is the superior orbital fissure. Again, to look at the anatomy, this is the central skull base, very poorly pneumatized sphenoid sinus, and these are the anterior clinoid processes on each side, and this is the end of the lesser wing of sphenoid. If you go more inferiorly, so we are now at this level over here, we are going to come into the lesser wing of sphenoid, which is going to form the lateral wall, of the superior orbital fissure. So this is a superior orbital fissure. We'll come back to that later on, but this is the lesser wing of sphenoid. A point to note that the lesser wing of sphenoid not only forms the anterior wall of the middle cranial fossa. Remember, the temporal lobes are going to be here. So this is the anterior wall of the middle cranial fossa over here. So it forms the anterior wall of the middle cranial fossa, but also the lateral wall of the orbit. So the lateral wall of the orbit, the floor of the middle cranial fossa, the lateral wall of the middle cranial fossa, and the anterior wall, all of that is formed by the greater wing of sphenoid, which medially bounds the superior orbital fissure, which is what we are seeing here. And just to understand the importance that the orbit has with the middle cranial fossa, this is a patient who has got this tumor over here. This is a meningioma, and if you compare the two sides, the bone here is sclerotic, significantly sclerotic as compared to that side, and there is a soft tissue which is in association with the sclerotic bone. This is the sclerotic greater wing of sphenoid, and this is an abnormal enhancing greater wing of sphenoid with some enhancement intracranially, excess new bone production. This is the anterior clinoid process, and this is the meningioma with the intraorbital component of the greater wing of sphenoid base tumor. So this is the superior orbital fissure oriented in an antero-posterior plane, and we have talked about this before. And this is the optic foramen, which is bound medially by the sphenoid and laterally by the anterior clonoid process. So and the optic struts. So this is the optic foramen oriented in a more oblique plane, and this is a superior orbital fissure, which is more or less in the anterior-posterior plane. So these are the greater wings of sphenoids definitions and extensions. Uh, and again, to highlight the importance of the greater wing of sphenoid with the orbit, you will realize here this is extremely deficient. There is absence of the greater wing of sphenoid, that abnormal mesenchymal tissue protruding into the orbit. The orbit is very extremely deformed. There is a lot of soft tissue there, and this appearance over here, this is the same person, this appearance over here called as a bare orbit, and that orbit is bare because there is no greater wing of sphenoid. And this is what we see when we do a CT scan or you do a skull. The vast lateral portion of the orbit just behind the behind the orbital rim is mainly formed by the greater wing of sphenoid, and its absence is going to give rise to this bare orbit appearance. And this is a person who has neurofibromatosis 1, von Recklen-Hausen's disease, with absence of the greater wing of sphenoid, causing this proptosis in this person. Uh, the greater wing of sphenoid, as I said, it's attached to the sphenoid body. So this is a person who has had recurrent meningitis, and we were evaluating the cause of the meningitis. And you can see this is the opacified sphenoid sinus. Normally it should contain air, like this maxillary sinus over here. This is a coronal view. This is a CT cystonogram. So this is the sphenoid sinus, and these are the greater wings of sphenoid over here, which will form the floor of the middle cranial fossa and the lateral wall inferiorly. And you can see the deficiency here at the junction of the sphenoid with the post sphenoid. So this is the sphenoid, which is going to form the greater wing of sphenoid, and this is the post sphenoid, which forms mainly the body of the sphenoid itself. And this is a deficiency over here, which has resulted in herniation of the meninges. And you can see that the contrast which has been injected via lumbar puncture into the CSF systems is now herniating into the sphenoid sinus, understanding why this person has recurrent infection. Moving on to the lesser wing of sphenoid. Okay, so the lesser wing, it's a much smaller wing. It is located at the superior anterior aspect. So the vast majority of the middle cranial fossa is bound by the greater wing of sphenoid, but the lesser wing forms a very small portion anteriorly and superiorly, and that's what we are seeing here. These are the greater wings of sphenoid. A lesser wing of sphenoid is a derivative of orbitosphenoid, and you can see how it has been shown that it has already got a small opening between the two struts of the lesser wing. So this is the lesser wing, and as it comes closer to the sphenoid body, it develops into two struts, which is what you are seeing over here. These are the two wings of, this is the lesser wing of sphenoid, and it has got superior and inferior strut where it attaches to the sphenoid body, and through this strut passes the optic nerve, i.e. this is the optic canal. Below that is the superior orbital fissure, and this is an MR scan, a bit difficult to conceptualize, but this is going to be where the bone of the lesser wing, and these are the two struts over here, the superior strut, the inferior strut, and this is the body of the sphenoid, probably very well pneumatized, and hence you're seeing it as black. And this is the optic canal, which is this structure over here in between the two struts of the optic nerve. So this is the optic canal within the two struts of the lesser wing of sphenoid. Moving on to the pterygoid processes. So we have looked now at the central sphenoid sinus, we have looked at the greater wing, we have looked at the lesser wing. Finally, we come to these two plates, which are more like the feet of the bird, if you like, and if I've got the lateral pterygoid and the medial pterygoid, and these hang inferiorly attached to the junction of the greater wing with the body, as you can appreciate over here. And this is what you're seeing over here. This is the maxillary sinus. This is the maxillary sinus, is going to be somewhere here, and just behind the maxillary sinus, are these two pterygoid plates separated by a very small space over here. And a lot more discussion about this when we talk about the pterygomaxillary, pterygopalatine, So maxillary or pterygopalatine fossa. So this is that small space which we'll spend time later on looking at. But for the minute, these are the pterygoid plates which provide attachment to the muscles of mastication, the medial and the lateral pterygoid muscles of mastication. And in this portion over here, you can see that there is a large destructive lesion here, which is placed based really at the pterygopalatine fossa, which is this small space over here. But you can see how the base of the pterygoid plates are destroyed and the pterygoids are eroded close to the skull base around about this area over here. So that was the final bit of the anatomy of the pterygoid plates. Uh, so that's the anatomy of the sphenoid sinus. So we have looked now at the anatomy. Now let's move on to the various communications in the foramina within the sphenoid, and to understand what are the structures that are transmitted through these various foramina. If you look at the sphenoid bone itself, it has an anterior component which is around about here, which separates it from the orbit in front and the maxillary sinuses and the nose over there. It also forms a floor. Along the floor, it is underneath the floor is of course a suprahyoid neck, and more posteriorly it rests against the petrous bone in laterally, and in the midline is the clivus. So the foramina are going to be oriented either front to back or superior inferiorly. So the foramina which are oriented front to back are superior orbital fissure, the optic canal, and the rotundum. The pterygoid foramen is also oriented in the anteroposterior, while the foramen ovale and spinosum, the foramen ovale and the spinosum, they are oriented supero-inferior in direction. And finally, we'll talk about the pterygopalatine fossa, which is a major junction, a very major relay station, which forms a very important landmark in discussions around the anatomy between the face, the maxillary sinus, the nose, the palate, and the middle cranial fossa. So let's look at these individual foramina. Okay, so foramen rotundum, which really houses the maxillary division of the fifth cranial nerve of the trigeminal nerve. Oops, sorry. Okay, just move back. Apologies. Okay. Foramen rotundum. Okay, so the foramen rotundum, as I've said, is oriented in an anteroposterior plane. This is as if you're looking from behind the sphenoid sinus over here, the lesser wing, the greater wing, and it is really close on the medial aspect of the greater wing of sphenoid that you see this foramen, and that's where the foramen would be located. The V2, i.e. the maxillary. The V1, which is the ophthalmic division, is going to go through the superior orbital fissure. So here we are looking at the similar anatomy in the coronal plane. This is the greater wing of sphenoid at its attachment with the sphenoid sinus, and this is the foramen rotundum, which is at the site of attachment within the greater wing of sphenoid, the superior orbital fissure just above it, and laterally the optic canal superior to the orbital fissure and much more medially. So this are the foramina rotunda, which transmit the maxillary division of the trigeminal nerve. And you can see, because they are oriented in the anteroposterior plane, when we do a coronal scan, you can see them as small circular lucencies. And this is that same person over here in a sagittal plane. So we have got the front with the orbit, the maxillary sinus. We are at the back over here. The brainstem is going to be here. This is the maxillary sinus. These are the pterygoid plates, the maxillary sinus, the pterygoid plates. And this is the foramen rotundum, which is oriented in an anterior-posterior axis. This is that same foramen rotundum oriented in an anteroposterior axis, and you can catch it as it leads from the middle cranial fossa into the pterygopalatine fossa before it does its business. And this is here in an axial plane. Orbit in the front, maxillary sinus is going to be below this level, maxillary sinus is going to be below this level. This is the foramen rotundum, which is this what we are seeing over here. The star is really the pterygopalatine fossa, which is around about here, the pterygopalatine fossa. So foramen rotundum, and the pterygopalatine fossa over here. And so this is the rotundum, which will house the maxillary division. And this is what we're seeing on an MR scan. In the coronal plane, we saw the optic nerves, but these are the foramina rotunda with the gray appearance of the maxillary nerves. So the maxillary nerves here or here contained within the foramen rotundum. So that's the anatomy of the foramen rotundum. Remember, the maxillary division is really a trigeminal derivative. So the trigeminal nerve with its Meckel's sitting within the Meckel's cave, coming from the brainstem, and we have looked at it in detail, the various divisions. When we talked about the cranial nerve anatomy, we have got the ophthalmic division, which goes through the superior orbital fissure, which goes through the superior orbital fissure over there. Then the maxillary nerve, which is V2 division, which goes through the foramen rotundum, which is here, foramen rotundum, which is here, which is foramen rotundum, and then the mandibular division, which doesn't really go in the front at all because it goes down, and you can see it's a foramen which is oriented, which is going to be oriented in a vertical plane, in that plane, and we'll come back to that later on. So right now, just to remind ourselves of the anatomy of the foramen rotundum and the contained maxillary nerve. Uh, so again, just to recap the maxillary nerve, the foramen rotundum, and a clinical relevance is, of course, because it is in communication with the face and the facial structures. This is a person who had a melanoma on the skin surface and developed paresthesia on the face, and you can see there is abnormal enhancement with a lump over here. This is a normal appearance of the normal foramen of rotundum, but certainly substantial enhancement, but also a lump here in the posterior aspect, on the inferior aspect of the trigeminal ganglion. And this in the coronal plane over here, normally if I were to just go one step back over here, you can see the foramen rotunda over here on this coronal T2 sequence, normal in size. And in this portion over here, normal appearance of the foramen rotundum over there, but substantially enlarged the foramen rotundum. So this is perineural disease spread along the foramen of rotundum, along the maxillary division. Uh, and this one of the most important nerves we talk about is this infraorbital nerve, and we saw it last week when it was involved with the fractures of the floor of the orbit. This infraorbital nerve goes through is a continuation of the maxillary nerve as it enters into the inferior infraorbital fissure and supplies the front of the face. And in this patient who had a carcinoma on the front of the face, and you can see the enhancement over here in the infraorbital nerve, and these are the muscles of the orbit. We saw it last week, but this is the enhancement. No enhancement on the other side, and the enhancement extends similar to that previous case into the foramen of rotundum. Not only to the foramen of rotundum, it has extended into the cavernous sinus. Not only has it extended into the cavernous sinus, this is a normal cavernous sinus, this is a normal foramen ovale with the mandibular division. Now this is a coronal plane, so this is a vertical foramen. Here you can see that the disease is spreading along the mandibular division as well. So the metastasis can jump across various divisions uh, along its way. But this example here really is to illustrate the anatomy of the infraorbital nerve, which is a continuation of the maxillary nerve, but also to show the anatomy of the foramen of rotundum. And we will come back to this later on. These are the foramina ovale with the contained mandibular nerves. And again, here infraorbital nerve, you will on this coronal sequence, normal appearance, abnormally enlarged. CT scan, normal appearance, abnormally enlarged. But also here on the CT scan, very vital to look at. If I have got any radiology colleagues here, this is the pterygopalatine fossa. These are the pterygoid plates over here. The small area over here behind the maxillary sinuses is called as the pterygopalatine or the pterygomaxillary fossa. Normally it should contain fat, this low density with a small amount of vessels and lymph nodes here. But in this person over here, this is that same person, you can see there is abnormal soft tissue within it, and that is because of infiltration along this infraorbital nerve into the pterygopalatine fossa, where the pterygopalatine ganglion resides. And this pterygopalatine, from here, disease can easily spread intracranially, and we'll look at the communications of the pterygopalatine fossa in a while. Moving on from the foramen rotundum, we will go on to the foramen ovale. Foramen ovale is basically transmits the mandibular nerve, and we have looked at the anatomy of the mandibular nerve in detail when we talked about the nerves. It's the only foramen which is of the trigeminal which is located, which is in the vertical direction. and hence it is best seen in the coronal plane. So here we have in the coronal plane, this is the central skull base. We are much more posterior now, and you can see these foramen which are kind of oriented much more inferolaterally, which are these structures over here. And this is on the MR scan. This is the central skull base. These are the Meckel's caves, which will house the trigeminal ganglion, and from there you can see the mandibular nerve descending down into the suprahyoid neck. The mandibular nerve is the nerve of mastication. It supplies the muscles of mastication, and these are the pharyngeal constrictors, and these are the lateral and the medial pterygoids. The nerve itself lies in between those planes and supplies the pterygoid muscles in the suprahyoid neck. And this is a CT scan, and a CT scan in an axial plane. This is again the anatomy, just to revise. This is front, this is back. We have got the clivus at the back. These are the carotid arteries. We have at the central skull base over here, these are the maxillary sinuses with the pterygo maxillary or the pterygo palatine fossa. As we come back, we have got this foramina ovale here, a fairly chunky foramen, because the mandibular nerve is a principal motor nerve for mastication, and very easy to identify on a CT scan. Just posterolateral to it is foramen spinosum, and we'll come back to that a bit later on. So here we have some clinical examples of foramen ovale and the contained mandibular nerve. So this is what it would look normally, but certainly enlarged. The Meckel's cave is certainly enlarged here. The foramen ovale is enlarged, and abnormal enhancement within that area, suggesting infiltration by the tumor. And here, just to illustrate and confirm that how the muscles of mastication can be affected in the same person over here, this is what the muscles of mastication will look like: nice and dark in structures and not really enhancing substantially. But when there is muscle involvement, you can see the high signal, and that is acute denervation. You can see it in the tongue. We have talked about this when we looked at the hypoglossal palsy, but this is acute denervation of the muscles of mastication, and they can enhance as well. So these are the medial and the lateral pterygoid muscles which are enhancing because of acute denervation, because of perineural invasion of the mandibular nerve. And this is a young child, and again an embryonic tumor of the nasopharynx with trigeminal involvement. And again, to remind us that not only the mandibular nerve not only supplies the muscles of mastication, but it is also a conduit to the to the to the parotid gland. It carries the parasympathetic secretomotor fibers via the auriculotemporal nerve. And we have looked at this example where there is carcinoma, adenoid cystic carcinoma of the parotid gland, which has spread along the along the auriculotemporal nerve into the mandibular division, and then eventually into the cavernous sinus. So just important to remember that the anatomy of the mandibular nerve and the divisions. In terms of the foramina which are oriented in the supero-inferior, we have talked about the foramen ovale. Another small foramen which is located just posterior to it. Remember again the anatomy. This is the wing of the sphenoid along just, so this is the wing of the sphenoid. We are looking at this this level over here, just beneath the temporal lobes. We have got the foramen ovale, and just behind that, this small foramen is foramen spinosum. And foramen spinosum transmits the middle meningeal artery, and this is what we are seeing over here, the middle meningeal artery here. This is a coronal CT angiogram. The temporal lobes are going to be here, the sphenoid sinuses, the carotid the carotid arteries on either side. This is the pharynx. These are the muscles of mastication surrounding the mandible, and these are the branches, distal branches of the internal maxillary artery, and one of them is the middle meningeal artery, which is going to penetrate through this foramen spinosum and then become intracranial. So the middle meningeal artery passes through that, and this is what it looks like. This is an external carotid angiogram depicted. The external carotid, of course, supplies a lot of the face, but it also supplies substantial component intracranially. And though it is called as a meningeal artery, it supplies substantial neural structures as well around the cavernous sinus. It's a principal supply to the third, fourth, sixth cranial nerves around the cavernous sinus, and also around the facial nerve via its posterior division. So middle meningeal artery, it's not just a meningeal artery, it's also a neural artery. It's very important to realize that. But coming back to the anatomy of the foramen spinosum, over here we can see that over there, and this is an angiogram, a lateral angiogram. This is the middle meningeal artery which has been injected. So understand it's going to be somewhere here, the injection, and these are the branches of the middle meningeal artery. So the foramen spinosum is at that level substantially enlarged, and this is a person who has got a fistula at that level with all the branches of the middle meningeal artery converging posteriorly along the lateral transverse sinus. So this middle meningeal artery is quite often involved in a significant proportion of fistulas at the skull base. The other relevance, of course, of this middle meningeal artery is as it courses laterally it is vulnerable to trauma, and is the artery which is implicated in extradural hematomas in children as a cause of rupture. The other small foramina, we are now into the smaller foramina. We have looked at the foramen spinosum, is the Vedian nerve or the Vedian canal or the pterygoid canal, and it is located much more inferior to the mandibular to the maxillary foramen or foramen rotundum. It's much more smaller. It also leads into the pterygopalatine fossa. You will now realize the pterygopalatine fossa behind the maxillary sinuses, in front of the pterygoid plates, and it really carries. Now I don't know if you will remember. If you remember the median nerve, we talked about the median nerve. It is formed. It contains the secretomotor fibers from the facial, the parasympathetic outflow from the facial, via the greater superficial petrosal nerve, and it goes through the Vedian canal, which is this canal over here between the sphenoid and the pterygoid over here, leading into the pterygopalatine fossa, and the Vedian nerve is formed by the greater superficial petrosal and the deep petrosal, which comes from along with the sympathetic outflow from the carotid arteries, and together they form the Vedian canal or the pterygoid canal nerve, which then subsequently relays into the pterygopalatine fossa and eventually on its way to the orbit. It supplies the secretomotor fibers from the facial nerve, and this is that small nerve, small canal over here. This is the patient with metastases following cancer of the hard palate, and you can see that there is abnormal enhancement here, but also enhancement extending along the pterygoid canal, and this is that pterygoid canal. Very small structure, but consistently seen on a CT scan, on a high resolution CT scan. Very difficult to appreciate on a MR scan unless if you do a proper sequences in the coronal plane. Moving on to the superior orbital fissure, and subsequent to that we'll talk about the optic canal and the pterygopalatine fossa. So the superior orbital fissure, and we have talked about this last week when we talked about the anatomy of the orbit. It really is a fissure in between the greater wing and the lesser wing. So this is the left orbit over here. And as I said, the greater wing of sphenoid forms a substantial portion of the lateral wall and the posterior aspect of the lateral wing of lateral wall of the orbit. And this is the superior orbital fissure. Superiorly, it is bound by the lesser wing of sphenoid. And it's a very important fissure. It transmits a lot of structures: the third nerve, the fourth, the sixth nerve, the ophthalmic division, but also the superior and inferior ophthalmic veins. Remember, the optic nerve transmits the ophthalmic artery and the optic nerve. The optic canal transmits the ophthalmic artery in the optic nerve. It does not go through the superior orbital fissure. So the superior orbital fissure contains all of these structures, and this is the location again on a colored diagram over here. Between this is the opposite side. So this becomes the greater wing of sphenoid. This is the lesser wing of sphenoid. The optic canal is a small structure over there, and this is a superior orbital fissure. You'll remember we talked about the annulus of Zinn, which is a muscular-tendinous structure which will provide attachment to the muscles of the orbit, which are then concentrated around this muscular-tendinous ring as they fan out anteriorly in a muscle cone to attach to the globe. To revise again this anatomy, the superior orbital fissure and the optic canal. So the superior orbital fissure, which is present between the greater and the lesser wing. So this is the greater wing of sphenoid. This is the lesser wing of sphenoid. This is the superior orbital fissure. The foramen very close at the level of the greater wing of sphenoid, and the body is the foramen of rotundum, which is here. These are the pterygoid canals, which are inferior, which we saw just now, and finally the optic canals, which are located above the level of the superior orbital fissure along the struts of the lesser wing of sphenoid. So here is the anatomy again. This is the anterior clinoid process, optic canals, anterior clinoid process, which is pneumatized, optic canal. These are the superior orbital fissure. So we are round about this level over here, the optic canal, which is medial, and the superior orbital fissure, which is lateral. Uh, uh, just some clinical examples to share. This is a person who has fibrous dysplasia of the planum sphenoidale, and this becomes the anterior lip of the sella. So the roundabout here, we will get the tuberculum sellae. This is the body of the sphenoid. Just lateral to that is the optic foramen. Just lateral to that are the optic structs and the clinoid processes, and just lateral to that is going to be the superior orbital fissure. Again, note the orientation of the superior orbital fissure more or less in the anteroposterior, while the optic canal is more or less in the oblique plane of the optic nerves. I shared this example last week. This is the patient with superior orbital fissure syndrome with inflammation causing painful ophthalmoplegia. And just to sort of recap via this example, to look at the various extensions and the various foramina, this is a very extensive tumor of the skull base. It's a meningioma which is attached to the petrous apex here at the back, which is based just lateral to the sphenoid sinus, which also extends anteriorly along the greater wing of sphenoid. So it is almost a spheno-cavernous petrosal meningioma. And here you can see how it's extended all the way to the skull base. Here it is all the way around the skull base. So this is the greater wing of sphenoid. Again, to highlight the anatomy over here, this is the greater wing of sphenoid. Greater wing of sphenoid with the cavernous sinuses. It has invaded the cavernous sinus. But also look at the extensions of this tumor now, extending anteriorly into the orbit through the superior orbital fissure, anteriorly into the orbit. This is going to be the superior orbital fissure over here, just medial, and above is the optic canal. So this is a superior orbital fissure, but also extending inferiorly. This is a normal side, this is the abnormal side. You can just about see the gray nerve over there. This is a coronal view. This foramen is best seen in the coronal view because it extends from superior to inferior, from the cavernous sinus region, from the Meckel's cave into the suprahyoid neck, leading into the masticator space. So this is our foramen ovale with the mandibular nerve, and this is extension of the tumor via the foramen ovale into the suprahyoid neck. So this is the mandibular nerve involvement by the same meningioma. This is the involvement of the superior orbital fissure and very likely involvement into the orbit. Not to forget, the superior orbital fissure also contains veins, and we have looked at this example when we talked about the venous sinus anatomy, the cavernous sinus anatomy. These are internal carotid artery angiograms, AP view and lateral view. You can see that there is a blush at the posterior aspect. So this is the internal carotid artery. There is a blush. This is anterior. This is posterior, superior, inferior, and the blush is on the posterior aspect of the cavernous portion. And you can see very early here, opacification of this structure, this vein. Remember, we are still in the arterial phase. This is the artery. These are still the parenchymal arterial branches. But here we are visualizing this vein, which is the superior ophthalmic vein in this person who has got a keratico-cavernous fistula. And this superior ophthalmic vein traverses through the superior orbital fissure, which is what is shown over here. If you have to just flip this over, so this is a carotid artery. This is that same carotid artery. The fistula is going to be somewhere here. Early opacification of the cavernous sinus, and one of the tributaries, which is a superior orbital vein, or ophthalmic vein, which is what we are seeing over here, which would be then responsible for the patient's presentation with proptosis and a pulsatile ecchymotic globe. Right, now the final 5-10 minutes, apologies, I'm going to overshoot again, is about the pterygopalatine fossa. And we have been sort of talking about it as we have looked at the anatomy of the foramen rotundum and also of the maxillary sinus last week. So it's a very critical junction. It's a box, pyramidal shaped box, which is located behind the maxillary sinus, also located behind the palate. And it's a key junction. It's a key junction because it's a relay station, and it's it houses the pterygopalatine ganglion, but there are a lot of nerves and an important critical vessel which travels through it. So let's just look at the anatomy over here. So this is the maxillary sinus. This is the orbit over here, the maxillary sinus. Behind the maxillary sinus is this pterygopalatine fossa over here, and we have got the sphenoid sinus in front with the pterygoid plates which will be hanging over here. So the pterygopalatine fossa is that structure here, which is what we are seeing over here. The maxillary sinus, the pterygoid plates, and this is the pterygopalatine fossa. So this pterygopalatine fossa uh, uh, communicates with various structures. It communicates posteriorly. We looked at it earlier on via the Vedian canal. It also communicates again with the foramen rotundum and the maxillary nerve. So these are the posterior communications of the pterygopalatine fossa. Laterally, it leads into the infratemporal fossa, which is the structure over here. Laterally is the infratemporal fossa, but also it leads into the orbit via the inferior orbital fissure. And we have looked at the infraorbital nerve and the perineural spread of disease earlier on as to how it affected the infraorbital nerve uh, and the pterygopalatine fossa. So these are the anteroposterior extensions. But what about and the lateral extensions? What about medially? Well, medially it communicates with the nasal cavity, and this is what we call as a sphenopalatine foramen. The sphenopalatine foramen, which is here, and it communicates with the nose. So the pterygopalatine fossa, which is located behind the maxillary sinus, communicates intracranially with the Vedian canal and the foramen rotundum. Laterally, via the pterygomaxillary fissure, it communicates with the infratemporal fossa and also with the orbit via the infraorbital canal. And medially, it communicates with the nose via the sphenopalatine foramen. And why is it so important? The clinical relevance will come fairly soon. Just to look at the imaging appearances, this is again the sagittal view: maxillary sinus, globe, maxillary sinus, globe, pterygoid plates, the foramen rotundum, which leads into the pterygopalatine fossa and the infraorbital canal, the foramen rotundum, which leads into the pterygopalatine fossa and will lead into the infraorbital foramen. And you can see the pterygopalatine fossa, it kind of recesses inferiorly towards the palate. This is where the palate would be. This is in the coronal view. This is in the axial view. We have looked at this anatomy earlier on, the location of the pterygopalatine fossa as it leads into the infratemporal fossa and posteriorly into the foramen rotundum. And this is in the coronal view. A little bit difficult to understand the coronal view. Remember, we are at this level. We are behind the maxillary sinus, so we don't really see the maxillary sinus. But what we see are the pterygoid plates. We don't see the maxillary sinus because we are in this view in the coronal plane. We just about see the pterygoid plates, and it is located just above the pterygoid plates in this location. Very important to look at the normal anatomy on MR scan. This is a T1 weighted sequence. You can see that the CSF is low signal. We have got a fat, and fat is a great help when we are looking at the anatomy of the skull base. Maxillary sinus here, a lot of fat within the pterygoid plates. This is the fat within the pterygopalatine fossa. This dark line is the line of the cortical bone, which what we are seeing. So the star is where this fat is, and the small rounded areas of low signal are branches of nerves and vessels within the pterygopalatine fossa. And in this portion over here, you can see it is abnormal with low signal because of disease which has spread along the nerves into the pterygopalatine fossa. And this is showing the enhancement within that same nervous structure. Uh, and the pterygopalatine fossa, we said, it communicates posteriorly. It also communicates inferiorly. It transmits branches to the palate. It transmits branches to the infraorbital foramen, but also transmit branches to the palate, and these are called as the palatine foramina. And this is a greater, and this is the lesser palatine foramen here, the bigger and the smaller one. And this is on the axial view. This was parasagittal. In the axial view, we have got a maxillary sinus in front, the pterygoid plates at the back, and these foramina are seen as oval or rounded areas here, the greater and the lesser foramina. And here you can see this patient who has got cancer, again presented with numbness around the lower face. You can see that the cancer involving the alveolar ridge over here spreading into this foramina, and hence this presentation of numbness, not to be taken lightly, is an early sign of perineural spread of disease. And just finally, another important structure that we need to talk about when we talk about the pterygopalatine fossa is the sphenopalatine artery. It is a branch of the external carotid artery. Here we have an external carotid angiogram, which with the superficial temporal artery, the internal maxillary artery, and the sphenopalatine artery. It is the sphenopalatine artery which extends from outside via the pterygomaxillary fissure and supplies the area around the pterygopalatine fossa, supplies the posterior nose as well, and is a crucial artery. ENT surgeons are more used to dealing with it, especially for someone who has epistaxis. This is the artery which gets ligated. Also, it is an artery which neurointerventionalists would embolize for persistent epistaxis, or also in this patient who has got a tumor which is supplied by this very enlarged sphenopalatine artery. You can see comparison between those two sites. And the tumor, the hallmark tumor of the pterygopalatine fossa is, apart from metastasis, the primary tumor is a juvenile nasopharyngeal angiofibroma, and it is located within the pterygopalatine fossa along its medial end, very close to where it communicates with the nasal cavity, the sphenopalatine foramen. And you can see how this young person has got a big tumor over here. It has widened the pterygopalatine fossa. This space is much more widened. This is a CT scan. Compare the pterygopalatine fossa to this dimension over here. It has scalloped the wall of the posterior wall of the maxillary sinus, extended laterally into the infratemporal fossa, but also medially into the nose. And this tumor is typically supplied by branches of the internal maxillary artery, which can be embolized prior to surgery. So those are the contents of the pterygopalatine fossa. I think that probably is, yeah, that's my last slide. So I think in effect, what we have done is we have looked at the evolution of the sphenoid bone itself, skull base. We have looked at the development of the skull base, the cartilaginous models of the skull base. We have looked at some of the embryogenesis behind it. Then we have looked at the sphenoid bone and the anatomy of the sphenoid bone, the body, the wings, but also subsequently the various apertures and foramina that lead from the sphenoid bone towards the face, towards the palate, towards the orbit, and with some clinical examples. Uh, and I think I'll stop there and I'll take any questions if you have. And just to remind, next week is our final week of anatomy discussions, which is going to be on posterior cranial fossa and foramen magnum. Thank you.